Good morning, everyone. First of all, I want to declare myself as I am not a big cardiac anesthetist or a cardiologist. Whatever I am going to tell now about simple things about reading an ECG. So don't do big mistakes. That is what is my concept is about. Before that, I would like to tell that my slides are available in website www.painfreepartha.com and my lectures are available in YouTube channel Pain Free Partha. So first of all, we should know that ECG is a lab investigations. We should treat patients and not ECGs. Many times patients go to a big corporate hospitals. Persons goes to a corporate hospital and some vague STT changes are there. He comes back with a big list of drugs for this so-called ECG changes. So many times it happens like this. So we need to treat the patients and not the ECGs always. ECG is a voltmeter, it's a voltage which is time, amplitude plus direction. What is my definition of this ECG is, it is a graphic representation of electrical activity of the heart recorded from the skin surface. This time, I want to thank Dr. RMV and other my cardiologist friends who have helped me to make these slides. Now, if you go to this sodium potassium pump, I'm not going into the details. This is sodium in. Sodium in is less calcium and potassium and sodium potassium ATPs. This is what is the cardiac cycle. Now I'm going again. This is sodium in. Sodium in is less. This is calcium. This is potassium out. And this is sodium potassium ATPs. So this is the genesis of PQRST. P is atrial and QRS is ventricular and T is ventricular deep repolarization. So always from the left it starts QRS complex, left to right, because the genesis of electricity is from left to right. I am not going to the details of this because it will be a big YouTube lecture. What are the leads? We have lead 1, lead 2, lead 3. That is bipolar leads. Lead 1 means right arm minus left arm. This is bipolar. Unipolar means VR, VL, VF. This augmented limb leads. Chest leads is from V1, V2, V3, V4, V5, V6. These are the standard limb leads and augmented unipolar leads RA, LA, LS, and right arm, left leg, and there are chest leads. These are the chest leads. V1 parasternal, fourth intercostal. This is left and right, and this is between V4 and V2. This is V4 midclavicular line. This is V5 anterior axillary line and mid axillary line. So this is the axis which we go again, the normal axis. Whenever we tell axis, we are telling about the QRS complex, not about atrial axis or T wave axis. QRS complex or axis means the main current deflection is towards this direction. That is what we want to tell. This is between minus 30 to plus 90, this area. So normally this is the axis. Now we will go to so many things. Here you see one small square is 0.1 millivolt here, and this is 10 millivolts. 1 millivolt, 10 millivolt. Here it is 20 milliseconds, and here you can see 400 milliseconds. 0.4 second, 0.02 second. So this is what is the big square is 400, 0.4 seconds. This is 20 milliseconds. 20 milliseconds and 0.4 seconds. 0.4 plus 0.4 is 0.8. This is 0.8 seconds. This is what we should be very again. This is 1 millivolt and this is 10 millivolts. Atria and ventricles contract simultaneously. Septum is from left and LV dominates. Axis is only for limb leads and there are so many intervals and segments. We will go to first technical considerations. Now if you see, the standard is like this, the ECG lead is like this. The standard is like this, then the ECG lead is like this. See here, the same patient, same lead, same time. If you have a standard like this, the ECG will look like this. If you have a standard like this, the ECG will look like this. The standard like this, the ECG will look like this. So be clear about the standard. See the standard, how it is before talking anything about the ECG. Now you see this is a standard. The same standard is like this. The same standard is like this. In nowadays, recent computerized ECGs, if the LVH is so big, no, that will cross the ECG paper, then what it will do is, that lead alone, it will decrease the standard. That we should be careful. That lead, it will be decreased only 5 millimeters the standard, and it will show within the graph. That we should be able to recognize. Understood? 10 millimeters is normal standard. 5 millimeters, when it goes automatically, if the wave is very high, automatically it will go. But here, the standard is high. So standard, we should see as normal. This is wandering baseline. See, baseline itself is wandering like this, and up and concave and convex. This is normal. Now, this is AC interference. You can see it is like ventricular fibrillation, but this is simply even regular spikes caused by electrical current. It is more regular and it is more even. So that is what we make it as current problem. Now, reading an ECG, yes, we have told about standardization. Now, there is name, age, sex, date, and time, because we cannot treat an ECG which is recorded 1 year ago. So, age, sex, name, because we cannot treat other persons. A short clinical history. For example, now we are seeing the heart rate is 50, 52 or something like that. See whether the patient is on beta blocker, whether the patient is on clonidine, if the patient has taken food, if the patient has taken exercise, done exercise, if the patient has got some disease like thyrotoxicosis. All these things make interpretation of ECG at different. Whenever you see a start ECG, now you're seeing standard, name, age, sex, clinical history, all these things. Now you go to the ECG stat. If you see lead 1 positive and ABR is negative, then okay. If that is not there, lead 1 is positive, ABR is negative, then start proceeding. Otherwise, we should know whether there is wrongly taken ECG or dextrocardia or something else. So lead 1 is positive, ABR is negative. Then you start seeing your ECG. Stepwise analysis, rate, rhythm, P, PR, QRS, access, duration, so many things. Yes, we'll go each. Now, if you want to see the rate, this is 300 divided by number of big squares with RR interval. R, 1R. RR interval. How many big squares are there? 1, 2, 3, 4, 5, 6. 300 divided by 6. That is almost 50 or 52 or something like that. Now, if you see the small squares, this is 1, 5, 10, 15, 20, 25, around 30. So 1500 divided by 30 is approximately 50 per minute. So this is how you should know the rate when the rate is regular. When the rate is irregular, similar thing, it is very difficult because RR interval itself will change. There, what we need to do. Now you see here, this is regular. RR interval 1500 by 16. 1, 2, 3, and one more is things there. 15 plus 1, 16. 1500 by 16 is 94 per minute. Here you can see 1, 2, 3, 4, 5, 25 plus 1 plus 2, 27. So it is around 56 per minute. So this is how it should be read like. When it is irregular, then what we should see is, now we know the ECG runs at 25 millimeter per second. You see 5, 10, 15, 20, 25. This is 1 second. Then this is 2 seconds. This is 3 seconds. This is 4 seconds. This is 5 seconds. This is 6 seconds. In 6 seconds, how many are there? 1, 2, 3, 10 are there. 6 seconds, 10 are there. In 60 seconds, 100 will be there. So if it is going to be irregular here and there, then you calculate for 6 seconds. 6 seconds is what? You have to see 5. 1, 2, 3, 4, 5 is 1 second. Because it runs as 25 millimeter per second. You have to run 25 millimeter to calculate 1 second. So if it is going to be 6 second interval, how much it is? Now normal sinus rhythm is 60 to 100. Sinus brady is less than 60. Tachycardia is 100 to 150. SVT is 150 to 250. Atrial flutter is 250 to 300. Atrial fibrillation is more than 300. This is what we should understand. People will ask, in atrial fibrillation, what is the rate? The atrial rate may be around 300. Because of the AV nodal delay, because of some drugs like digoxin, we have pushed the ventricular rate to 70 or 80. So that doesn't mean your atrial rate is 300 or not below 300. It is around 300 only. So atrial fibrillation, heart atrial rate is around 300, but may be decreased by your AV nodal delay to 110 or 100 or the ventricular rate. But if it is fast, then you call AF with rapid ventricular rate, AF with RVR. Now you see the sinus node tick, 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 does at 60 to 100. The atomicity. Now you see AV node at 40 to 60 and ventricular 15 to 40. Now there is a problem here. Then there is a nodal rhythm and the node will be around 60 only. And if there is a nodal rhythm with a heart rate of 85, then it is nodal tachycardia. AV nodal start பண்ற things cannot be the rate between around 89 or 94. So that is how it is. AV node is 40 to 60. Its intrinsic atomicity is around 40 to 60. So what is the rhythm? Normal sinus, tachy, brady, arrhythmias. Brady and tachy sometimes in the same lead, it may be six sinus syndrome. Yes, these are all clues. That doesn't mean six sinus syndrome should always have this. Same lead, brady to tachy, sinus. So this is normal sinus rhythm, 60 to 100. 1, 2, 3, 4 is there. 300 divided by 4 is 75. The normal sinus rhythm, regular, because this RR interval is regular. And there is a P wave before each QRS complex. And the PR interval is P starting of P to the finishing of P here, starting of QRS complex. This is 0.12 to 0.2. How much is the 120 milliseconds? So 20 milliseconds, 0.4 second. So it is around this. So if it is more than that, then it is prolonged PR interval. So this is normal sinus rhythm. See here, lead one positive, AVR negative. Then only you should start seeing things. Sinus bradycardia means it is a less than 60 per minute. 1, 2, 3, 4, 5, 6. 300 by 6 is 50 per minute. Regular. You have every PR peak, then followed by Q. P followed by Q. Every complex is normal. Then it is sinus bradycardia. Everything is fine. P wave followed by QRS. PR interval is normal. Everything is fine. Then you get the rate is around 120 or 130. Then it is called sinus tachycardia. You have sinus bradycardia causes and treatment, sinus tachycardia causes and treatment. Everything is fine. QRS complex is normal. P wave is fine. P wave is followed by QRS. Everything is fine, but there is some irregular RR interval. This looks like a variation of respiration, sinus arrhythmia. Now we will go to the P wave. It should be seen in lead 2 and V1. Lead 2, V1, P wave. Lead 2 corresponds to right atrium and V1 corresponds to left atrium. This is a simple maths. In lead 2, right atrium, if it is more than 2.5 squares, then it is called right atrial enlargement. In this, if it is more than 2.5 squares, then it is left atrial enlargement. Now, either it may be, this is here, right atrial enlargement, more than 2.5 squares. Left atrial enlargement, see, more than 2.5 squares. This is called bifid because it is bifid. This is biphasic. It goes beyond the negative to go this neutral to go negative. This is biphasic, more than 2.5. This is bifid, more than 2.5. Both are evidence of left atrial enlargement. So P is a 2.5 problem. PR interval normal is 120 to 210 milliseconds or 0.2 seconds. If you have first degree heart block means all P wave will have one QRS complex. All P wave will have one QRS complex, but PR interval is prolonged 250 milliseconds. This is what is called first degree AV block. If some of the P waves are conduct to the ventricles and some are blocked, 10 P waves are there, but only 8 QRS complex is there. Then it is second degree block. Third degree block is there is no connection between P waves and QRS complex. P waves are running like this and QRS complexes are running. So this is what is called third degree heart block. So it is all, some, none. Now we can see this is the lead one. You can see the PR interval is prolonged here. So this is the first degree AV block. Now we can see this is the P wave, this is the P wave, there is no QRS complex, P wave, there is no QRS complex. This is second degree heart block. Sometimes third degree heart block with P wave, P wave, P wave, P wave will be going on. There it will be this thing. So complete third degree heart block. Now sometimes first degree heart block, what was told? Only prolonged PR interval. Second degree heart block, some are conducted and some are not. In this, there are two types. Two types. Type 1 is ventricular, where it is, you see here, PR interval is prolonged and slowly it increases to cause a drop beat. Slowly PR interval is normal here. PR interval is prolonged here. PR interval drop beat. PR interval is 0.2 seconds, 0.24 seconds, 0.28 seconds, drop beat. This is what is called ventricular. Slowly PR interval prolongs to have one drop beat. But in type 2, that is not ventricular. Type 2, that is more dangerous. There is no connection between this. Both type 1 and type 2 are second degree heart block. Why? Some P waves are conducted, some are not. This is what is called second degree heart block, where it is type 1 is slowly prolonging PR interval followed by a drop beat. So complete heart block nodal QRS can be broad, his or ventricular. Here you can see complete heart block. So first degree may be rheumatic arthritis, carditis. Second degree may be danger and fibrosis of the his bundles. Now PR is short, very short here. Short, 0.12 second, little less this. It can happen in pericarditis or atrial infarction or WPW syndrome, where we can see a short PR interval followed by a delta wave. Something slurred QRS starting is called delta wave. So now we have talked about P wave, PR interval, etc. Now we will go to QRS complex. QRS complex is not always said like this. If you have a complex like this, it is QS. It's a small q, big R. Big Q, big R. Big Q, small r, like this. So it may be different types. It may be a small q, big S, small q, big R, RS. So many types of QRS complexes are there. When do you take a Q wave as significant? Usually the Q wave is significant when it is more than 1/3 to 1/4 of the total complex. Now you can see this is almost half. The Q wave height is almost half of the total QRS complex height. Then it is pathological Q wave. Now Q wave is pathological. Voltage maximum 2.5 squares. That is what is QRS complex. 2.5 squares. More than that, then it is prolonged QRS, wide QRS. That's what they say. Voltage criteria, LVH, RVH. Duration is about LVB, RVB, VPCs, and axis. Now we will go to LVH. R V file. V file R. Yes, V1 is more than 35. Here it is 1, 2, 3, 4, 20. Here 1, 2, 3, 4, 20 plus 20, 40. R V5. Yes, V1. You add this. If it is more than 35, then it is called LVH. And if single lead AVL, if it is more than 11, what are the other evidence to say LVH? There may be left axis deviation. Left axis means what? Lead 1 is positive, AVF is negative. I'll come again. LA enlarged. LA enlarged, what are the criteria? 2.5 problem. V1 la, the width is more than 2.5 squares. Voltage, LVH, isoelectric ST sagging. There is no Q wave. T wave inversion is there. This is voltage criteria. When there is a volume overload, you can see the Q waves here and the T waves are tented. So this is more of a volume overload LVH. Volume overload LVH is different. Here you can see tented T waves. There you can see ST sagging. Volume overload is mitral regurgitation. aortic regurgitation. Pressure overload, LVH, is where we get concentric hypertrophy is aortic stenosis and hypertension. Aortic stenosis, hypertension, pressure overload. Aortic regurgitation, mitral regurgitation, volume overload, where you get this stented TVs, where you get eccentric hypertrophy. So what is R by S is more than 1. Then you call it as RVH. R in V1 plus S is more than 11. So it should have a wide QRS complex L, small QRS. That's what RVH is. R is, see here, big, V1. R is quite big. So QRS duration is normally 2.5 squares, I told. 40, 40, 20, 100 milliseconds. If it is 100 to 120, it is called IVCD. If it is more than 120, it is called widening BBB. Cause of wide QRS complex: bundle branch block, LVB, pre-excitation, ectopic, tachycardia, SVT with aberrant conduction, pacemaker rhythm. Now what is this LVB? QRS is wide. You get RSR complex and ST may be depressed. You get where? Left ventricle V5, V6. You get this, what is this known as RSR dash. This is the V5, V6, but it may be inverse in V1, V2. So this is what is classical of LVBB, left bundle branch block. RBB, it is equal M pattern in V1, V2, RSR pattern in V1, V2. And there may be R by S may be 1. Wide QRS may be there. Wide QRS means what? More than 120 milliseconds. So RBB here can M pattern, but there is no wide QRS complex. QRS complex is narrow. This may call it as partial or incomplete RBB. If you have a complete RBB, then you have M pattern with wide QRS complex. Now you see this is normal RBB and LBB. In V1 itself it will be inversed. Now you just check in LBB, V5, V6 it will be M pattern. Okay. In RBB, M pattern is in V1. The reverse can happen. This we should be keeping it in mind. There are two things. Left anterior hemiblock. This only is blocked. And this is fine. Left anterior hemiblock is usually found out by there is no cause, but there is a left axis deviation. But if you have a left posterior hemiblock, you will have a right axis deviation. So left anterior hemiblock is nothing else is there but left axis is there. You have an RBB is unlikely to have left axis deviation. RBB, but you have left axis deviation. Then it is called bifascicular block. If you have LHP, RBB and prolonged PR interval. What is this prolonged PR interval? First degree heart block. Left anterior hemi bundle is gone. Our right bundle is gone. Only LA posterior is there. All these prolonged PR interval. This is called trifascicular block. So what is, you are told left axis, left axis. What is this axis? Minus 30 to plus 90. QRS. Very simple. If you have lead 1 positive and AVF negative, it is left axis. If predominant, if you have lead 1 negative and AVF positive, then it is called right axis. Now you see this is the right axis deviation. Predominantly lead 1 is negative and AVF is positive. This is right axis deviation. Where predominantly lead 1 is positive and AVF is negative, then it is called left axis deviation. This is right axis deviation. So there is another method where the waves is equiphasic. Equiphasic, na positive and negative are almost similar. Then this is which wave? Lead 1. Perpendicular to this, the axis is. That is, it is looking towards 90 degrees. Now sometimes you see here, where is the equiphasic? This is the equiphasic. This is about lead 2. Where is the lead 2? Lead 2 is here. This is perpendicular, AVL. So here you can see this is also equiphasic and this is also equiphasic. Then we call it as indeterminate axis. Some cardiologists usually write no indeterminate axis. This is what is indeterminate axis. ST segment more than 2 millimeter depression and after 80 milliseconds downsloping ST is dangerous. But if this high takeoff like this, slightly upstoking, then it is slightly more likely to be benign. Now there is concave ST elevations, convex ST elevations. ST elevation more than 2 millimeters from the baseline. So it is convex like this or concave like this. It may be pericarditis or Prinzmetal's angina, or it may be convex. This is the classical infarction. Convex, and if it is persistent like this, after some time, then there is a development of aneurysms. So this is ST segment and this is J point. See here the J point is depressed camel. You see horizontal ST depression, horizontal, then there is a convex, oblique, everything is there. Oblique depression. So concave, hammock, boat shape, this is digoxin effect. This is ischemia. Understood? This is secondary T waves likely because of LVH or bundle branch block or cardiomyopathy. There is no obvious ischemia. ST segment depression less than 1 millimeter, upsloping ST, high takeoff or normal. Less than 1 millimeter, then it is normal. So what is about T waves? It is positive in leads except AVR. Tends to diminish with age. Always greater than U wave. Less than 5 millimeter in limb leads and less than 15 millimeters in precut. This is very important. If to say it is a high T, very peak T waves, then we should have 5 millimeters on 15 millimeters in precardial leads. Now, asymmetrical T wave inversion. See, for example, this angle is different from this angle. When it comes down, the angle is around 45 degrees. When it goes up, it is around 90 degrees. This is called asymmetrical ST depression. Lowered edge point, this is likely to be a secondary wave. Likely to be a secondary wave. The patient has got an LVH, so this is a secondary. But here you see symmetrical. J point is slightly elevated. Then peak T waves. Then it is likely to be an ischemia or a primary T wave. Secondary T wave, there is no possible ischemia. Maybe due to LVH, the T wave is inverted. Now you see the height, it should be 15 millimeters. Here 1, 2, 3 in the precardial leads, or it should be 5 millimeters in the limb leads. Now what is U wave? Small rounded following a U wave, approximately 10% of the amplitude, maybe in V2, V3, it's larger at slow heart rate and diminishes and merges with a T at faster heart. Now you can see this is U wave followed with less height and only seen in V2, V3 predominantly. U wave is more than T wave, then think hypokalemia. U wave is inverted, think coronary artery disease. U wave and T wave is merged and inverted like this, think of stroke. Now this is classical U wave and T wave merged and inverted C wave. Measures duration of electrical activation. QT and electrical activation varies inversely with cardiac rate. Corrected QT interval. Upper limit is 460 milliseconds. Normal is, what is the peak square? 400 milliseconds. Now you see, this is extreme, around 15 millicurrents. Only ventricular fibrillation is there. So potassium is around 9. There you can see the PR interval is prolonged, peak T waves. And here you can see the potassium is normal. PR interval is normal, QRS is normal, T followed by a smaller U. Slowly you see the T wave is merging and U wave is becoming bigger. Then you see your potassium is T. This is hyperkalemia, tall peaked T waves, short PR intervals. Now if you go to calcium, calcium is high, then QT is less. Calcium is low, QT is big. This is what is. Calcium contracts fast. Think of QT is shortened. This is hypocalcemia. See, get T when it starts. This is prolonged QT interval. So maybe you understood, but don't worry, be happy. This is sinus arrest, almost like going like. This is a premature atrial contraction. See here, this is a premature contraction. Premature atrial contraction is coming like this, followed by a compensatory pass. This is SVT. SVT is what? More than 150%, and we don't have P waves. But QRS complex is normal. It is not wide. If you have an SVT with LVB, then it is possible that you have wide QRS SVT. Usually ventricular tachycardia is wide QRS. SVT is narrow QRS. But if you get SVT in the presence of bundle branch block, then you can have wide QRS. Supraventricular tachycardia, atrial tachycardia, regularis rhythm, atrial flutter. This you can see the flutter waves. Atrial rate is 220 per minute. Now this is atrial fibrillation. These are fibrillatory waves. Atrial fibrillation. I've already told the atrial rate is around 300 to 350 per minute. But because of the nodal delay here, the ventricular rate is around 100. What is junctional rhythm? It starts in the junction. So P wave may be there, P wave may not be there, P wave is altered, everything happens. Now SVT, unstable DC version, we know carotid sinus massage, adenosine, verapamil, beta blockers, all these things. Narrow QRS tachycardia is very simple. If you have tachycardia narrow QRS complex, preferable drugs, but broad QRS tachycardia may be short. If you don't know anything, this is SVT or PSVT, prefer amiodarone than verapamil. We can give for SVT also, we can give for ventricular ectopics also. Unifocal premature ventricular contractions. This is from one focus of the ventricle, not from multiple focus of the ventricle. This is bigeminy, one normal, one abnormal, one normal, one abnormal. This is coupled PVCs. This is not one normal, one abnormal. Two abnormals and two anormals. You can have triplets. This is non-sustained VT. It is going 4 or 5. Then it becomes non-sustained VT, slowly goes to sustained VT. Now, T wave is there. If an R wave falls here, then it is what is called R on T. Then it becomes likely to become tachycardia, ventricular tachycardia. So we should not get R on T. That is what we do in defibrillation when we synchronize. You have a contraction so that the heart is not on T. If it is on T, then it will not deliver. That is what is important. So R on T should not be there. R wave should not come in T waves. So R on T means slowly it will become like this. So right ventricular PVC, when the ventricle is from there, see here, negative in V1 is RVC. This is left ventricle positive in V1. Very important because left ventricular PVC is more likely to be malignant. So these are all the importance. Arises from RV, smooth configurations, unifocal, isolated, away from T wave because R on T is dangerous, can occur in normal heart. But if it arises from LV, multiple, some BP changes, R on T phenomenon, already there is a disease heart, then we should need to treat this VPCs. 6 is coming, multiples are coming, couplets are coming. So all these things, in runs it is coming. More than 6 to 10 per minute are coming. Multifocal are coming. Then it is likely to be treated. And this can wait and watch. What is the difference between a premature contraction, extrasystole, early, but an escape beat comes later? Now you see, the SV node is blocked, AV node is blocked. But ventricle tries to escape from it. It's not contracting. It gets its own atomicity. It contracts at 40. So this comes little late. But this is also irregular rhythm. But escape beat comes later when premature beat comes earlier. So this is ventricular fibrillation, where we need this thing only. This is ventricular asystole. What is Brugada syndrome? RBB with ST up in right precardial leads. ST segment may begin from the top of the RBB. There is a risk of ventricular fibrillation. This is one of the indications of a pre-operative ECG where if we get Brugadas, be careful, tell the patient. Reading an ECG is walking on glass. So what is this? This everything is normal, maybe some AC interference. So what is this? You can see the P wave. This is gone. PR interval is slowly prolonging. All P waves are not followed. Some are missed. So this is second degree AV block, but prolonged followed by missed beat. So ting, tung, tung, tuck. So that is what is called second degree AV block, Wenckebach's type 1. So these are special waves, delta waves, Osborn waves, hypothermia, and epsilon waves. What is this? This is fibrillation. AF control is verapamil, beta blockers, and digoxin. Rhythm control is amiodarone. All these things we can go and read. So this is now, this MCL was there long back. All these things I've got now. Our clinical first name, date, and standard. Lead 1 AVR, lead 1 positive, AVR negative, then you are in seriously. PP interval, R and RR intervals, various intervals, QT, PR intervals, QRS and axis. Lead 1 positive, AVF negative, left axis. Lead 1 is negative, AVF is positive, then it is right axis. ST, what is the primary T wave inversion? What's the secondary T wave inversion? So homework, thank you very much. Yes, my slides are seen in painfreepartha.com, freely downloadable, and my channel is painfreepartha.